the semester. Thank you guys all for logging in, and I hope everyone's semester is ending well and everybody is nice and healthy. I don't really have any announcements besides the fact that this is the last one for the semester, so we will be starting again in September. We'll do the first Wednesday of September again, and we will be doing that throughout the fall semester as usual. And as always, after tonight, I will be posting the link for this, so you'll be able to go back and review it if or share it with our other students. So I'm gonna introduce our speaker for tonight, Dr. Herb Wolfe, who is currently the Chief Medical Officer. He's the Executive Director for the Chief Medical Officer at the U.S. Department of Homeland Security. He previously served as the Director for Medical and Public Health Preparedness Policy at the White House National Security Council and as a Technical Intelligence Officer at the CIA. Before going to the White House, he was U.S. Department of Veterans Affairs, Veteran Health Administration's Chief Audit Executive, and providing independent and objective oversight for the organization's $66 billion annual budget and 300,000 plus employees through proactively identifying system vulnerabilities, overseeing and implementing enterprise risk management assurance activities, and leading all internal audit functions across the clinical, business, and financial domains of the global VA healthcare system. Immediately prior to his appointment at the VA, he served as the Senior Advisor to the Director at the Centers for Disease Control and Prevention's National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry, a role in which he provided strategic direction and vision, advanced environmental health priorities, and helped to ensure the department fulfilled its critical mission of using the best science in taking responsive public health actions to prevent and mitigate harmful exposures and diseases related to toxic substances. He served as the senior agency official forward deployed to Flint, Michigan in 2015, leading the public health response to the water crisis. Wolfe served on active duty in the U.S. Public Health Service as a physician assistant from 1998 to 2002, completing his family medicine residency at the Claremore Indian Hospital in Claremore, Oklahoma. He began his federal career in 1993 as a biological sciences laboratory technician with USDA Animal and Plant Health Inspection Service. And we are also, we both graduated from the George Mason Biodefense program, which is how I got to meet him online. And I thought he would be a great person to come talk tonight. He's got a lot of interesting work he's doing right now, specifically with COVID, on top of everything else he does at CWMD. So Dr. Wolfe, thank you so much for speaking with us tonight.
Sure, thanks for having me. Thanks, Jennifer. So given that we're in the middle of a pandemic and you guys are the public health preparedness part, I deliberately cut about half of my slides out, and I wanted to leave a good amount of time to talk about COVID, which is probably 14 hours of my 16-hour day. And so I thought that would be a great discussion. Just before I came on, we were meeting with the government of Mexico, trying to ensure that the southwest border, mainly for our issues around detainees, we're having some trouble with testing and validating antibody and antigen testing. And so we were on a call with the government of Mexico to make sure that their health system is stable, because clearly if their health system is not stable, then there's likely that our health system on the southwest border won't be as stable. So I created a few slides. Thanks for having me tonight. I would say feel free for folks to interrupt. I didn't put them in any order. I just thought I'd give a general overview, and then like I said, I cut a lot out. So if there's areas that are important or folks have questions, I would say just feel free to interrupt me. And with that, let's see if I can do this right the second time to share my screen.
When he's doing that, if you have a question and you want to interrupt him, you can unmute your mic. And I'm also monitoring the chat here. So if you would prefer, you can type your question and I'll interrupt for you. So either way, you can either type or raise your hand or just unmute and ask it.
Okay. Jen, do the slides display okay?
Yep, I can see them.
Okay, well, I should get an IT certificate as well. That's an accomplishment. So the first thing, of course, I have to caveat with any presentation I make is that, you know, I'll give you guys some views and some opinions during my briefing tonight, and they're sort of my views, and they don't represent either the leadership of the department or the government writ large. It doesn't mean anything I'm going to tell you isn't factual. It's just sometimes we'll have some, you know, we probably will have a discussion or a question, and I'll give you, you know, my opinion as a government official versus the official opinion of the government. Clearly, for those of you who don't know, the mission of the DHS is pretty simple. It's we'll safeguard the American people with honor and integrity, depict the homeland and the homeland's core values. The office that I'm currently in, which is the Countering Weapons of Mass Destruction office, was established in December of 2017. So it's a relatively new organization within DHS. And in the organization, two prior organizations within the department were combined. So the first one was the Domestic Nuclear Detection Office, sort of exactly what it sounds like, address nuclear terrorism, both domestically and with international partners. And it was merged with a unique office called the Office of Health Affairs. So DNDO had a director and the Office of Health Affairs had an assistant secretary who was also dual-hatted as the Chief Medical Officer of the department. So that office more or less did all of the public health preparedness and health security for the nation within DHS. So those combined together, and we have the Combating WMD office, which is the full scope of WMD, CBRN threats, and then health security threats added in at the bottom. The one caveat you'll notice there, I put an asterisk. So one of the functions within health that we did not bring over is the workforce health protection. So that is things like workman's comp, credentialing of providers, quality assurance. We put that over to a different organization called the Undersecretary for Management. So all things health operations resided in the office that I'm in now. So if you think about things like preparedness and response activities, emergency management, emergency medicine, care of children in custody, care of detainees, and then all of the operational response plans stayed within OHA, and just workforce health went over to a different directorate within the department. So I thought I would just give you, this isn't an all-inclusive list, but I thought this might be the things that are interesting for you all to hear about that we have for our responsibilities. So there are several key things that we do. One is we lead the department's EMS program. So we actually have our own EMS program, individuals that are certified and work for us. We have roughly 3,100 EMTs and paramedics in the department. So it's a pretty large EMT program, and that is managed out of my office. We are the principal medical and public health advisor for S1. So S1 is government lingo for the secretary, and F1 is government lingo for the FEMA administrator. And then we also clearly advise all of the other department senior leaders on public health issues. The ones we interface with the most are Customs and Border Protection, clearly for child and detainee issues at the border. We deal a lot with ICE Health Service Corps for ICE issues for detainees. And then we deal a lot with US Coast Guard. Clearly, Coast Guard is a little unique. They're a uniformed service, and they have their own Coast Guard Chief Medical Officer, Rear Admiral Dana Thomas. But there's a lot of things we do unified across the department, so we work with them quite a lot. We lead the department's traditional biodefense activities, so this is exactly what you think of it. And then we also I serve as the department's senior official for an organization and group we call the Public Health Emergency Medical Countermeasures Enterprise. So that is the FEMC. And just to give you a little sort of current news about that, that is normally led by Dr. Rick Bright, who you probably have seen in the news a little bit lately. He was the director of BARDA over at ASPR. And so that is a group within HHS that really works with the interagency to determine what medical countermeasures we're going to invest in and develop across the federal government. We coordinate our internal countermeasures program. We also lead the Food, Ag, and Veterinary Defense Program. So we are the department's lead for the One Health Initiative. And then we also serve as the department's lead for ESF8. So those of you who know your incident command and your FEMA lingo, this is the National Response Framework. ESF8 is public health and medical preparedness. So we support in the department's lead for ESF8. And I asterisk next to the ones that I'm going to give you a few more slides about tonight. So EMS in DHS, it's a rather unique program. You can see down at the bottom, we go from traditional to tactical, and we go from urban to austere. And so between Coast Guard, Immigration, TSA, Air Marshals, FEMA, training centers, Federal Protective Service, and the Secret Service, and then our Air Border, Air Marine, and Air Field Ops for Customs and Border, we have a pretty diverse EMS program, and there probably is not one EMS program that works in the same community, addresses the same community, and works in the same environment. So we have multiple tactical ones, multiple austere, and they're not the same. We have some that are wilderness austere in the Northwest, and we have other ones that are austere in the desert, and they're 2 hours away from any type of care at all. And so the EMS program, we run at a federal level. So most of these folks are nationally, all of them are nationally registered, certified EMTs and paramedics. And we manage the credentialing and the privileging, the protocols, the medical oversight, and then at the headquarters, we do the on-call 24/7 reach back, as well as the case review studies for each of the EMS runs that we do across the department. Again, these are just the organizations that we support for EMS. I told you we have about 3,000. We've got a DHS paramedic or EMT in every state and territory, and on about 13 tribal nations. Most of our providers are actually law enforcement officers, almost all of them. I would say we probably have less than 100 that are full-time paramedics or EMSs. And what I mean by that is it's a collateral duty. It's sort of like if you work in the federal prison system, you'll be considered a correctional officer or a guard first, and then you're a medical provider second. All of our EMS providers are full-time employees. We have no part-time and we have no temporary. So all of our EMTs and paramedics are all full-time employees of the department. So some would ask, hey, why do you guys have such a large and robust EMS program? Well, first of all, we have it for force health protection. We have a lot of individuals, frontline law enforcement officers, who work in austere frontline environments, and sometimes we have to do care under fire or care under injury. We also care for dignitaries and a lot of areas where we have senators and congressmen, presidential visits, state governors, and others who come to visit. Often these visits are in very austere environments away from larger facilities or larger or higher levels of care. And so we have to provide that. We care for all of our detainees. Right now, I will tell you, our detainee population is rather low, but I'm sure in the last few years, you've been able to watch on the news and understand that our levels of detainees have gone up markedly, especially during the months when we have migrant movement. We also do mutual aid and auto aid, so meaning we will support other state governments and federal agencies. And then we take a large part of our effort is on illegal aliens or individuals in custody at the border. And most of our DHS resources are non-transport. However, there are 2 fire-based systems. So really what we mean by that is we really are not running ambulances with our 3,100 individuals. What it really means is folks are out in their normal duty vehicle and they happen to be a paramedic. And so minus very few, ambulance or fire-based systems, we really are managing and providing care out of the law enforcement or tactical vehicle that individuals are working for their daily operations. These are just some photos of the different levels of care that we provide here. And as you can see, they're in all environments. And so it does make it really challenging to have one set of standard protocols for the entire department to follow. Next, I'll transition to biodefense, probably one of the more important topics and one of the ones I get the most questions on when I usually speak. Biodefense is a really interesting term, as Jen was saying, where there's a small group of us who actually went and got our master's and PhD in biodefense. And so it's a very narrow field, but it's a very broad field. And so we have a few things that guide us within the department when we talk about biodefense. The first is we've got the National Biodefense Strategy. It was signed the month I left the White House, so September 2018. It's called an NSPM. For those of you who've been around, sometimes we call things PPDs, sometimes we call them HSPDs, now we're calling them NSPMs. Those all mean the same thing, they're just a different acronym based on a different president. So under President Trump, we call them NSPMs, National Security Presidential Memoranda. Within the biodefense strategy, it's got a lot of priorities and pillars, but one thing that is unique in this new one is it actually stood up a full-time detailed team called the Biodefense Coordination Team. And that is a group led by HHS, and we send as DHS an employee forward, and they spend their time at DHS and they do things like inventory the BioResponse and biodefense capabilities across the government, inventory of equipment and personnel, new policies and procedures across the department, and trying to do a whole of government approach to biodefense, and including working with folks like ASTO and NATO to make it sort of a whole of community instead of just a whole of government approach. I mentioned FEMC a little bit ago. I'll elaborate a little bit more. So it's HHS led with ASPR as the lead. CDC, NIH, and FDA are our partners along with DoD, VA, and USDA. And we coordinate the development and the acquisition and the stockpiling of the medical products and countermeasures. So not just medical therapeutics and diagnostics, but also it would be equipment, whether it's IV, whether it's ventilators, whether it's N95 masks, all of the things that you could think would be important in the current pandemic environment that we're in. Another one that doesn't get a lot of attention, but I think it should, and it is, the administration has done a great job of putting effort on this, is the bioeconomy part of biodefense. So the bioeconomy, for lack of a better word, is the US economy. This is our intellectual property, it's our DNA data, it's our biome, it's all the information that we produce and share, whether it's research, science, health protected data, 23andMe, Ancestry.com, whatever it is all this stuff that has a value, a very large financial value. And this is a process the US government is putting in place to, one, protect our competitive advantage, two, just to basically protect our individual protected information, and three, to boost our competitiveness. So it's a relatively new term in government speak. For a lot of you, and probably the true science, the medicine field, this probably does not come as a surprise to you, and it's probably not a new term. But I will tell you, in the government is relatively new for us to put biodetection, bioresponse, and bioeconomy all in the same sort of vernacular. Biodetection is exactly what you think it is. It is developing detectors to detect either naturally occurring or man-made potential release. For those of you who have been around for a while, one of the programs that falls under this is the National Biowatch program, which is just a field of sensors that we, filter collectors that we field across the US at certain locations. And those filters are pulled on a routine basis, and they are sampled to find out if there are levels of certain agents or markers that we're looking for. But this is also trying to close that window. Clearly, going out and pulling a filter, sending it to a laboratory is not where we want to be in the 21st century. So there's a lot of R&D and S&T that is going on to try to narrow the window, sort of what we call the detect to treat. And so we're trying to narrow that window down because if a plume goes over a filter at 12 a.m. and the filter was pulled at 11 p.m. and it's not pulled to 11 p.m. the next day, you potentially have a long period of time, 23 hours, before the filter is pulled, another 8 to 12 hours before it's processed. So as you can see, we're already at the 36 to 40 hour window. And then for some of the agents we're concerned about, it is already potential that signs and symptoms have started to show up. And so biodetection is a big field. It's a costly field. We've struggled with some progress, but we're working on some replacements for our current effort, which is called BioWatch. The last one is probably something you may not have heard of. It's been around for a few years. It's a small program. It's called the First Responder Vaccine Initiative. And what this is this is a program where we take expiring anthrax vaccine and offer it to state and local or tribal or territorial governments free of charge. And we will administer the anthrax vaccines to law enforcement, EMS, and first responder personnel. We currently have 2 undergoing, Missouri and Mississippi. Clearly, with the pandemic going on, it's been a little bit of a slowdown. But this is one where the government has paid a good amount of money and has expiring vaccine that has been extended through shelf life. And so this is a program where Congress authorized us to not only administer, but to do the follow-up to find out things like what are the side effects, what are the challenges with documenting the administration, what is the compliance rate for follow-up. What are the side effects? What is the sort of the mood and appetite between unions and associations like IAFF for firefighters and NAEMS to find out if there's actually any buy-in. And then it's also to produce a long report for Congress to sort of say, there's a lot of cost involved with giving a vaccine away. So what the government often does will say, we've got a free vaccine, we're going to give it to you. We're wonderful. The government is giving you a free vaccine. And what we don't account for is, well, what if someone has to take a week off from side effects of the vaccine? Who pays for their sick leave? Who pays for the person to fill in while that first responder or firefighter is off? Who pays for the side effects and the follow-up if there are any? And so administration, storage. And so this is also a way for us to educate our legislative counterparts that when we say something is free, something is never free. And if we want to do this in a meaningful public health protective process, then we need to go back and give Congress some type of report so they know what would be entailing if we did this either nationwide or offered it nationwide. So right now we're doing it in two jurisdictions, St. Louis, the city of Missouri, and for Mississippi, it's the state of Mississippi. So probably one of our larger programs, and a unique one, is the Food, Ag, and Veterinary Defense. And so we have the lead for the department to coordinate all of our food and agriculture infrastructure, health and economic events for food. We are focused on catastrophic threats. So some may say, well, you know, we have USDA and we have FDA. They are absolutely a key partner, and actually USDA leads ESF 11, which is our agriculture sector, an emergency support function. But we are focusing on the catastrophic events that would come. So we're talking mainly agro-terrorism or high consequence events. Some have discussed in the last few weeks that maybe we are close to that with the issues around ConAgra and Tyson's and a few of the other meat packing and meat processing plants. I would say we're not there. I mean, this is talking a catastrophic loss of crop, either from a pest, intentional or naturally occurring. While certainly we have some risk in the food supply chain, those are really being led by USDA and FDA, and we're supporting them. But this is really Food Ag Vet from a catastrophic perspective. One, to prevent it, one, to do the risk analysis, another to implement a national plan, and then to make sure we have resources that are informed by the risk and the constraints. One of the things that we are working on pretty handedly on the COVID pandemic is the issue of lack of PPE and counterfeit PPE for those who work in meat processing plants. So as you can imagine, there's been a shortage of PPE, and as they always say in disaster management, never let a disaster go to waste in terms of trying to learn and trying to understand how we should respond. That's the same for private industry. There's always going to be nefarious actors who produce counterfeit N95 masks, who produce counterfeit masks, produce counterfeit gloves. And so we are trying to help to make sure that those in the critical sector, whether it's health or whether it's food ag or whether it's energy, that they have PPE that meets the NIOSH and OSHA approved standards. We have the NPPTL, which is the National Personal Protective Laboratory here in Pittsburgh. So they are the ones who do all the testing for NIOSH on that. So we work with them and partner them with our Customs and Border Protection individuals who do inspections and seizures of counterfeit PPE. We have a unique law that tells us what we need to do. It's passed in 2017. It's called the Secure Our Agriculture and Food Act. And that is what directs the Assistant Secretary and then myself and the others in the program to carry this out. I'm not going to read the whole slide, but it's pretty basic government speak. It tells us to manage a program. It tells us to make sure we have an integration between veterinary public health, traditional public health, food defense, and agricultural security. It tells us we need to have a plan. It tells us we need to coordinate with all the departments and agencies. And the last thing it does is it says we have oversight and management of the department for HSPD 9. So HSPD 9 is the Homeland Security President Directive 9, which is the defense of U.S. food and ag. It is currently under revision. We hope with everything going according to plan that either this month or next month the president will sign a new directive. This one is quite dated, and so we are in the final throes of updating our HSPD 9. It will no longer be called HSPD 9, but it'll be the new U.S. Defense of Food and Agriculture. So lastly, I'll go to ESF 8 supporting activities. I didn't put much on this slide because it's a lot, and this is where COVID-19 falls in. But I thought I would just review a few things since I've arrived at DHS, arrived back at DHS since September. So The first large mission that we're still doing and ongoing is the care and custody of detainees and children along the southwest border. For anybody who has followed or reads open source or just follows the mainstream media, clearly this last summer and fall, we had a rather large surge of children in custody at the border. And so our effort there was to work with our colleagues at Customs and Border and others to make sure that we had providing the standard of care that is acceptable in the US. And that's a struggle at times because these are not, Customs and Border Protection is not a healthcare system. They don't run a healthcare system. They're a law enforcement agency. They're a public safety agency. So this is really hard when you're trying to run and deliver healthcare, but it's in a setting and it's in a facility or facilities that are not meant to provide health or healthcare. They're meant to really provide basic healthcare for up to 48 hours while they're screening individuals, and then those individuals are moved along into the system. And so if you're not familiar with sort of how the, for lack of a better word, how the apprehension and the detainee population works at the border, CBP was never meant, it is not meant to hold individuals for months at a time. It is, they are apprehended, they are identified, a normal process occurs, they are screened for, urgent issues, someone who maybe appears to be having a stroke, a heart attack, someone who has a current infectious disease, someone who appears to be febrile, influenza-like illness. And then those people who are sent out for treatment. Then everybody else within a few days is supposed to be processed through what we call the federated immigration system. But when the system gets overwhelmed, it backs up. And so those individuals become in the care of the department and DHS for longer than is ideal. And so our office is a very small office, tries to provide medical oversight, medical guidance, medical direction, and medical support to help do things. Like we try to make sure that CONOPS and healthcare standards are adjusted from adults down to pediatrics, and then in the middle for young adults. And so that was probably, when I came to the department, that was probably the first, what I'll call, public health crisis that we faced, was the care of detainees and children. Certainly now, although the migrant population has significantly lessened due to some of our actions taken at the border by both the Secretary and the President, we certainly need to be mindful that we certainly do not want a highly infectious or a viral agent to be an outbreak. So there are things we are doing proactively in case we do get to a point where we have some outbreaks in our custody. Right now, it's been pretty good. We have another part of the department called ICE, which is the immigration part. Customs is sort of the U.S. Border Patrol and the Customs and Border, and then we have ICE. They certainly, like anybody else who has a detained population, whether it's a jail, a prison, or an immigration holding facility, we have seen some of our numbers increase in the last few days for detainees and immigrants held in our custody. And so we often are going through and looking at things like, how do we alter our care? We recently fielded some of the quick testing that Abbott Labs has put out so we can test our detainees more quickly. And then the other thing we do is we work to make sure that when we're repatriating or sending individuals back to their country of origin, that we're trying to make sure that when we send them back, they're not currently symptomatic or they're not an asymptomatic carrier of COVID. So that's sort of been number one of our public health sort of supporting activities. Number two is probably about a month ago, we thought we were finally going to declare the Ebola outbreak in the DRC over. We've had a few additional cases of an outbreak, so we haven't officially done that yet. But we've been working on the Ebola outbreak in the DRC for this entire last 7 months. So that's sort of been the second public health, event or issue that we've been working on. We don't have a large role in that because it's not here in the homeland, but we certainly have a role because we've got DHS employees all over the world. And as part of the interagency that has a good health presence, we partner with HHS, the National Security Council, CDC, and others on working on the Ebola in the DRC. And then, the last one, which is probably the largest one, has been COVID. And COVID has been a very, what I'll call a non-traditional. So first of all, it's a pandemic, right? And so we have not had a declared pandemic in this country in a really long time. So I want to caveat by saying this is nothing similar to Ebola. This is nothing similar to detainees at the border. It's nothing similar to when I spent time in Flint, Michigan. It's not similar to Fukushima. It's in a whole new realm of its own. And so, but we're also following a non-traditional approach to the response. And so normally in government, we have a thing called HSPD 5, and that's our management of domestic incidents. And that is normally the framework. It's the National Response Framework, it's NIMS, it's ICS, it's got emergency support functions, we've got supporting annexes. It's like the framework or the operating manual for how the government will respond on a large scale. We have not been following HSPD 5 for our response. We have been following, and I'll put in quotes, following or using. We've been using PPD 44, which is, enhanced response to domestic incidents. It's a newer presidential directive signed in 2016, which is sort of for those incidents that don't rise to the level of a Stafford Act declaration, like you would think like a Hurricane Maria or Hurricane Gustav. But yet here we are talking about using that in the realm of a pandemic, right? So in one breath, I'm telling you, PPD 44 is for these sort of unique responses that may not be as a large enough scale to have a large Stafford Act. So for comparison, when I responded to Flint, Michigan only had a Stafford declaration for bottled water. So the federal government had a declaration to dispense bottled water. The public health mission was not a presidential declaration, and we used PPD 44 to respond. So HHS, where I was at the time, took the lead, and people like HUD and USDA partnered with us on what we called a unified coordination group type of structure. So for COVID, we're sort of doing it non-traditional. We have the White House Task Force, and so that's led by the Vice President. And then under that, we have probably two very strong career individuals. I mean, for those of you who haven't watched, we've got Dr. Birx and we've got Dr. Fauci, both career federal employees, both well-versed in the public health and the clinical medicine lane, a fellow Penn Stater and Dr. Birx. And so they are sort of leading the public health and medical part of the task force. Then under the White House Task Force, we have sub-task forces, and those are things like community mitigation, community-based testing, hospital preparedness and resilience. And so we have about 8 of those task forces that are led by an interagency group of individuals that work either virtually or some people are over at FEMA headquarters. And so task force led by the Vice President with many strong medical people, but the two prominent ones are Dr. Birx and Dr. Fauci. The US Surgeon General, I believe, is on there, Admiral Giroir, the Assistant Secretary for Health. And then from time to time, you'll see Dr. Hahn, the FDA Commissioner. You'll see Dr. Redfield, the CDC Director. So we have people coming and going. For HHS, it's our Secretary and our Deputy Secretary who are on the task force. And they come and go as Homeland issues are there. Then we've got the sub-task forces, and then you've got the departments and agencies doing their thing. And so the things that we focus on most as the medical office internal to DHS has been our detainees and our care and custody individuals. It has been one of the things I do, we probably spend hours a day on this, is we review all the therapeutics and diagnostics for the administration. So for example, I'll give you some things that happen. We will get a group that want to advocate for, or we get a belief that a certain medicine, whether it's Plaquenil or whether it's Ritonavir or something else, we will get these medications, and a group of people will come together from a science perspective, mainly NIH, FDA, DOD, DHS, VA. We will review them, and then we send a recommendation forward up through the task force to the White House Task Force. So we review a lot of therapeutics and diagnostics. Certainly, there are many, many vendors and manufacturers creating both lateral flow, real-time PCR, antigen, antibody, point of care. We probably could review 50 technologies a day, and we probably have the bandwidth to review probably 6 or 8. And so one is that sort of reviewing technology, one is reviewing countermeasures, one is the care of individuals in our DHS custody, and then the largest portion of my time has been the health and welfare of the employee. So anything from specific questions of, I'm mission critical, I need to come to work in a classified SCIF, but my wife is in month 3 of chemo treatment, or my husband is 3 months after completing his treatment. I live at home with a vulnerable individual. I have an elderly parent who lives with me. Even questions in the world we live in, I'm a fur dad, I have a dog. We will get questions about, if I don't feel well, what should I do? And can I stay in the same room as my dog or my cat? And so we are here that if we don't have a healthy population at work, we don't have a mission. And so a lot of my time and my colleagues' time is spent on reassuring the workforce and then working on how we're going to return to the office. And that is a big struggle because this is not a flood where the water is receding and you can clearly see where the harm is at and where the harm is no longer at. This is a situation where each state is different. Parts of states are different. If you live in DC, for example, some of the wards are at a very different place than some of the other wards. We have employees that come from West Virginia. They may have a different stay-at-home order than the District of Columbia. Some folks travel from the Commonwealth of Pennsylvania whose return to work order is different than Maryland. Some states have mandatory cloth face coverings. Some states do not. Our federal building is in the District of Columbia, so we need to follow the guidance of the mayor on when buildings are going to reopen and how people can use mass transit. And so a good amount of our time is spent ensuring that the workforce is safe, how we're going to return people to work. And then for someone like me who likes to more often than not speak medicine or clinical terms, we got to translate that to layman's terms for the majority of the population, that when I say antibody or antigen, those are two words I have to stop and re-clarify for the entire workforce. I need to explain the difference between the two. And then when you talk about antibodies, then you got to explain IgG and IgM. And so imagine trying to sort of rattle off to the workforce twice a week. We do town halls twice a week for about 45 minutes. You don't want to give technical information, but you want to give rigorous scientific information based in science. And so it's a very hard challenge. And so that is probably where the majority of my time is spent in my office. And then the last place is the food supply chain. We have had significant struggles in the past month. For those of you who are following, some states, their largest outbreak in numbers of cases, minus nursing homes and veterans homes, has been meat packing and meat processing plants. So you go and look at places like South Dakota, Iowa, Kansas, a good portion of their numbers are going to be from those facilities. So our Food Ag and Vet team has been working with USDA and FDA to find out what we can do to help protect the workers, to help ensure we can get the economy back up and running. It's a balancing act between keeping healthy people, promoting good science, promoting good healthcare, promoting good personal hygiene, promoting social distancing, promoting staying at home, and then also making sure we're promoting people need to return to work. People are very nervous at home. We focus on the number of deaths from COVID, but one of the things that is not getting enough press is the rise in deaths from other illnesses, right, or other comorbidities. And so, you know, if you look across New York, they've got a large increase in deaths that we likely believe is not related to COVID. And the question is that individuals, you know, having an MI or something else that are not coming to be seen because of their fear to acquiring or catching COVID. And so while we're focusing on the public health emergency and pandemic of COVID, there also is a small group of us that are working with our counterparts in law enforcement and EMS to make sure that we also are seeing a lot of individuals that are not presenting or going for care what they normally would. Strokes, heart attacks, dialysis is another one. And so those are leading to a strain on the EMS system, which in turn is of course a vulnerability to the homeland. So I think with that, I'll stop and see maybe if we have any questions. That gives you a broad overview of what the office does. We have about 27 people, so sounds like a lot to do with just a pretty small staff.
Well, thank you very much for that. So I've got the chat open, and okay. I will also open it up for any questions.
Thanks, Herb. This is Gene Langridge. Very good, very informative. Do you have modelers within your realm then? And so what kind of models are you guys looking at to figure out what to do?
Yeah, so actually probably one of the harder questions to answer, Gene. So, you know, I have to be careful how I say this. So we certainly do have the National Biosurveillance Integration Center, actually is in our organization called MBIC. And so they do some of our modeling and what I call data analysis for us. We don't, as a country, I would say, I guess, we don't suffer for lack of models. And certainly models are great. You know, sometimes I say models tell you what they need to tell you, and sometimes they don't tell you what you don't want to hear. But we do work with the interagency and try to use a consistent and standard model. So one of the things I will tell you is, you probably noticed about 4 or 5 weeks ago, we call it the Gates model, but the model out of Washington, the IHME. That sort of was a model that Dr. Birx and Dr. Fauci sort of started to talk about. And so that's become, I want to say, for lack of a better word, the de facto government model, certainly run by academia. It's not our model. We don't put in the assumptions, but it's the model we've been following. And I think individuals like that for several reasons. One is, it was one of the first models that was easily visible to see the number of ICU beds and ventilators. And if you took social distancing or stay-at-home type of activities, you could see the change in the model. So in other words, you could see when Pennsylvania had a curve of projected deaths, apex, plateau, and then the downward slope. You could see the difference when, for example, Governor Wolfe implemented stay-at-home order. And so I think that was one with anything in a large organization, whether it's government or private industry, when the senior leadership seems to buy in or validate something, that's the one you follow. And so I think that's been one we followed. We leverage HHS a lot. HHS, between them and CDC, have several entities that do modeling and data analysis. So those teams are working together. The ASPR folks have a SIM organization. CDC has clearly done modeling for years, both domestically and internationally. And then DHRA has partnered with some of the group from the DoD part of it to do some modeling. And so there isn't one, like, for lack of a better word, we had this conversation the other day in a small group, Gene, which is, we don't have the US modeling agency. Like, we don't. And the question is, should we? I don't know. We joked back in the day, we used to have a thing called the US mapping agency. And it was like all maps came from the US mapping agency. And the question is it time, when this is all done and it's time for lessons learned and lessons observed, do we want to go back and find out, we've had so many models, do we want to put the brain power and the computing and the great brains and assumptions and some of our great academic institutions, because we've got the national labs, DHS has their center of excellences. Do we want to sort of have one area where the best model could be developed? Some would say you're creating an agency that's too big to fail. It's like single point of failure. Others said sometimes we've been chasing model after model, and it's been challenging to the decision maker and it's been challenging to the public. I will tell you, on a personal level, I have older parents who are here in rural Pennsylvania, and my mom will find a model on the internet somewhere and call me, and it's hard for me to talk to her about what the model is saying until I actually spend a few hours with it myself to understand what it's saying and what the assumptions are. And so I can only imagine, someone like, a parent of mine who's got access to me to call, but I can imagine the lay public, when they can log on to Facebook or Twitter or Instagram, and there's another photo or a real live interaction of a model, and it's not saying the same thing. It's sort of the issue we have now with the number of COVID counts. CDC's number is different from World Health, is different from John Hopkins, is different from the Worldometer. And so the more information you put out there in the world of what I call information instant gratification, we face a challenge. So we don't have one model. We've got access to a lot. I think it's going to be an area of focus when we get completely on the other side and we're losing no individuals every day, or we're losing very few. We will get to a point where we need to talk about data and modeling.
Yeah, so it has been quite an issue. I guess and just the stark change in the same model estimates is really causing quite a mass media flurry. And so people really don't know where to go with that information. I mean, that hits us here at home. That's a constant discussion just between a half dozen people that are able to communicate about those different models and what assumptions they go into them.
Yeah, I think a great example is up until maybe 5 or 6 days ago, the IHME model was roughly around the 60 to 67,000 deaths by August, right? And all of a sudden they had to readjust that, and their baseline reasoning for changing that was two of their assumptions changed. One is the reopening of some states mitigated the effects of social distancing. Their second one is we continue to learn about the virus, and so now I think the last I looked, we might be at 134 or 137,000 deaths around August 3rd, based on their projection. Well, if someone looked at that model a week ago, it was half of that. And so I think that is hard for the average U.S. citizen, the average person who wants to learn, and the person we're actually trying to convince that science and medicine is leading the way. I often joke with people. I say, medicine is science practiced by humans. What could go wrong? I mean, right? I mean, a lot could go wrong. But however, that doesn't mean we need our strongest advocates that when we're changing the model, we owe it just as much to talk about the model when we roll it out, that when you're going to change the assumptions, it needs to be a full court press to explain to the American people why that happened. A great example today, it's not a model. Someone emailed me about the CDC numbers for the National Database for Vital Statistics and said, the number of deaths is way off on this versus the number of deaths I'm seeing on TV. And I had to explain to the person that there are people that are going to wait weeks for a final a death certificate that gets entered into a database. Families may elect for an autopsy or may not. State governments may say they're so overwhelmed that an autopsy is not possible. And so if an individual likely died of COVID, but in the rush to, to process, 75 or 100 dead loved ones in a hospital facility, someone checks pneumonia or influenza, the databases are never going to match. But I think to an astute citizen, to an invested, neighbor who looks at that, they see a website run by CDC that says only 44,000 are dead from COVID, but they're looking on TV and they're seeing 67,000. And I think when the numbers don't match, it allows people to wander a little bit if some other things that mainly they're being told are not actually accurate. It's a struggle. I mean, it's an absolute struggle.
Yeah, well, that would be, that certainly is the case for the public, but I would expect it's also a problem within the response system too, within DHS too.
Certainly, we are you, right? I mean, the government is supposed to be a representative of the nation, right? And so, when I'm not at work, I'm a citizen like you. I live in DC, but spend some of my time here in State College. It certainly is a challenge for leaders, especially for what I will say the non-STEM and non-clinical or non-medicine leaders. It is very hard for them to understand the numbers. I'll give you another great example that I spend a lot of my time is the difference between death rate and case fatality rate. I got to tell you, Gene, there's some days I almost lose myself in exhaustion trying to explain to people that talking about a case fatality rate is not an exaggeration to cause hysteria. And that the case fatality rate simply means I'm not talking about you unless you're a case. And I have had to use every analogy from, there are 10 people in a home and all 10 die. 7 die from carbon monoxide, 3 die from an opioid overdose. The death rate is 100%, but the case fatality rate is 100% for both cases, opioid overdose and for carbon monoxide. But you could spend hours doing that and then you're not doing the response.
Well, gosh, that puts a whole new perspective on the when teaching in epidemiology, we go through case fatality rate and rate, and I feel like this is just so boring and simple. It's so obvious that I don't want to spend more than 2 minutes on these topics. I mean, I have a slide with about 8 or 10 different things that we might call rates. Or some disciplines might call rates and some might not. And I just I feel like this is just so simple. I just blitzed through that slide in about 5 minutes and it's got some very different things, but now I know I need to spend some more time on each of those and develop some good examples, good illustrative examples of each of those now.
Yep. Yeah, I tell people what would be useful is, I remember when I was doing my residency, they gave me these laminated handouts, and it was 1, how to communicate with a patient in Spanish, and 2, it was a pictorial to try to go over major organ systems, like here's the heart, here's the reproductive system. And I jokingly said to someone the other day, I hope someone in academia comes up with one of those, and it's a go-to for the common definitions that a clinician or a medical person or a healthcare or a public health a provider needs to go over with lay people to help them better understand the epidemic or pandemic that we're in. And I always gravitate to case fatality rate. There are other ones like recovered. Someone needs to come up with a common definition of what a recovered patient is. I think there's a confusion about a COVID death, but a COVID death with ILI potential. A COVID death with pneumonia is and so it would be really wonderful. I know it's asking for a lot, but I said, I hope someday I'm somewhere and someone says, here's this laminated sheet and I can just carry it with me sort of, like it was in my lab coat pocket to every meeting. And when a leader who is an engineer or who is an astronaut or who is a social worker or is anything not related to using these terms every day, I could pull it out and say, read this for a little bit and then let's talk.
Yeah, I
Sounds like an
remember.
interesting idea for an independent study project. Hint, hint.
I remember those first charts seeing recovered on them back in late February, early March, and somebody asked me, what does recovered mean? And I said, I have absolutely no idea what recovered means, and I still don't know what it means.
Yeah,
I think it's disappearing from charts, isn't it?
So it is, and I'm not sure we know. I think initially, I've recovered seemed to be those who were off of a ventilator and discharged, right? But then we got individuals who were tested positive, were listed as a positive and didn't seek care. And then we started to see some states include those in recovered. And my answer was, if you were always asymptomatic, how are you recovered? Yeah, I guess your recovery is getting over the news that you were positive, but you were asymptomatic the whole time. So you're right. It's been a challenge.
Well, I'll pause there. Thank you. I've got more questions, but I'll let other folks jump in if they have some. Looks like you got something in the chat here.
Yeah, I'm going to jump in with one from Mike. And speaking of asymptomatic people, so in preparing for the next pandemic, what capability gaps has COVID exposed in terms of screening travelers and migrants at land borders and ports of entry? Or for that matter, the general public, when early suggestions like using thermal imagers don't detect significant portions of asymptomatics?
Okay, I feel like Mike might have been in one of my staff meetings today. So great question, absolutely. So I will say two things, and again, I say this is certainly Herb Wolfe's opinions. There are several steps to a response, and one of them is called containment, right? And the other is called mitigation. And so I think for COVID, I think one of the things we learned is that guns, gates, guards, and ballards do not stop a virus. And for those of us who live and work in the public health, medicine, clinical science, healthcare, public health system or profession, we knew that. But remember, a lot of times actions that individuals take is to exude confidence, to promote safety message to the public. And so we did do a lot of airport screening. And for the longest time, we weren't doing temperatures, and then we did temperatures. And even when we put the China travel in, it wasn't a full ban, right? It was a travel restriction, but certain individuals, US citizens, nationals, spouses of citizens could still travel home. Well, the virus didn't really read the executive order. The virus doesn't read, the virus doesn't look at that and say, oh, there's a travel ban from, Hubei or Wuhan or all of China, but, US nationals or US citizens still travel home. I'm not going to do that. And so that was the containment mission. The mitigation, I think, mission was more along the lines of doing robust contact tracing, right? Doing wider spread testing immediately. And so I think what we've learned, at least in my mind, for one of the things we've learned early for the next pandemic is you've got to do containment mission and mitigation mission, both as robust at the same time. So in other words, if you want to do a law enforcement land event, an LOE, a port of entry, an airport of entry, airport screening, maritime screening, and that is screening, asking people if they're ill, taking a temperature, standoff, thermal if you want to is great. Then you've got to do just as robustly this mitigation, which is people who are symptomatic are immediately followed up. There's a process in place. We've got a robust public health system, not only at the federal level, but at the state and territorial and tribal level. And so you need to do both. The question about asymptomatic, it's a struggle, right? So if you talk about thermal imaging, two things come to mind. If you're asymptomatic, you won't have a fever, you're not going to be detected. The second one is, I think there are some studies over the last few years, thermal imaging has been used in the Far East and in some Southeast Asian countries. People who don't want to be surveilled or monitored might likely know if they take 2 acetaminophen 2 hours or 1 hour before they go to the airport, they're likely not going to have a fever and they're going to go through screening just fine. I think the other thing we've learned is the health community and the economic community. So in other words, the HHS and the ESF8 community and the President's National Economic Council, there's got to be some synergy there, which is people need businesses and travel open. If we are all of a sudden are doing thermal imaging, and let's just say I'm making this up, for every 5,000 people screened, we have a 500 with a temperature, what do you do with them? Do you send them to the airport counter to get their ticket canceled and they get a refund? If the government does thermal imaging and we say you can't travel, are they entitled to a refund? We don't have healthcare providers federal level at every airport. Do we just send them to the local health department, the state and local health department, or the local hospital? And if so, how do we make sure that a federal program isn't overwhelming state and locals? And so it's a really great question. It is one that I think is going to get just as much attention as the one I talked about earlier. And so I think this one will be one where how can we employ technology and how do we employ individuals? Herb Wolfe is one of the few people who believe the most astute detector we have in the world today is the clinician. I still think that's probably true. Maybe that won't be at some point in time, but if we are only relying on sensors and detection and they have certain limits or certain capabilities, and people are aware of those limits or vulnerabilities, they're going to exploit them. The other part of it is, it's like if you're going to have a gate and you're a turnstile and it's automated and you're going to prevent people from going somewhere, you have to have a processing lane or a processing system to process them when you boot them out. And so if Atlanta every day would screen people and 500 people fail their temperature reading, and let's just say it's 99.4 or above, we got to have a process. Where do they go? How do they get a refund? Who tracks them? Who keeps track of their data? Who has access to their data? Who makes sure privacy isn't violated? Who makes sure certain ethnicities, minorities, nationalities, religions are not targeted? It is an area that's going to take a large group of people across not just the federal government, but state government, associations, academia, nonprofits to try to figure this out. But we likely need to figure this out sooner rather than later. I don't want to tell you that we've got the answer because we don't. Clearly, we did a lot of airport screening for COVID. And I think what we learned is once it gets here, at a certain point, your ability to do containment has no more value. And I think maybe we learned that a little too late in this one.
So another question that I had, so my son is planning to get married August 28th in Pittsburgh with 200 people invited. What can you tell me about whether that wedding is going to go on as planned, and can DHS set up a perimeter for us to help us out with that?
So I would say make some really cool cloth face mask. If everybody's a Penn State fan, then make sure they're Penn State. If they're not, okay. Secondly, don't allow any Ohio State face coverings at the wedding. Yeah, so that, you and probably many other people, the one thing that those of us who work in the response, I tell my staff not to forget about, for every one of us that still has a job and is coming to work and feels overwhelmed from the response, we have many people that, high school graduations, college graduations, weddings, funerals, things that people need to attend that are life-altering events are not happening. I don't know what August is gonna portray for us. I wish I knew. I think a lot is gonna matter on what we do in the next 30 days. I think a lot of it is gonna learn. There are some research activities that entities have done that says clearly as we get warmer and more humid, the virus is gonna be less likely to be survivable outside, and it's gonna help us with our numbers. But I'm also mindful that sometimes I'm in State College in early June and it's like 45 degrees. And so, I don't know what August is going to look like. I tell people it's probably better to plan that something important is not going to happen. And then if the world does well, we do well here, Pennsylvania does well, then you have a pleasant surprise. But I know we're just trying to figure out now when we're going to reopen training academies for our law enforcement officers. And, I don't know when that's going to happen, and that's a priority effort, but we have some in Maryland, we got some in Georgia, we got some in California. We think all three are going to open on very different timelines. And then I think the last thing is going to be is, are we going to continue, or will we still have hotspots in certain areas? And so you may be able to have an event, but certain people traveling from, I'm making this up, this is random, but Arizona or Washington again, or North Dakota, some places are just like we have now, where New York City was the problem. I just don't know. I don't know. I wish I knew. We keep getting asked if we have any insight into college football. Well, I would not be working for the government if I could predict what college football is going to do. But if you look across the Big Ten, I believe Iowa and Purdue have both announced practice will start in June. College is back on campus. Maybe Penn State will announce that soon, but I think the reason some are and some aren't is geographically, this is a very different reality for people, depends on where they're at.
Well, you gave me a lot more serious answer than with which I asked the question. So, but I do have a problem because I originally came from Ohio, so there'd be a lot of Ohio families coming.
Oh no.
Well, okay, well then put my advice down as anonymous.
So Joan asked a question that I was going to as well, and she wants to know, what are your biggest areas of concern or uncertainty? Nursing homes are my freak out area now, but I want to know what's worrying people who know more than I do. I worry that the weather will not be much help in facilities either, where few people are getting outdoors.
Yeah, so that's a great question. So I would say what I worry about is that I worry that people think we know more than we know. We don't know a lot, and I think we need to acknowledge that. I mean, we call it novel coronavirus because it's novel. I worry about misinformation. I mean, I really do. I continue to worry that people react on the information that they hear and that they believe, and so I am concerned that we're not doing a good enough job of getting the right information out to the largest group of people. I do worry about that. And so, I think some of the things we don't, certainly the comment about nursing homes, I mean, absolutely. I think I just read in the paper today that I think Center County had, 5 or 7 more cases. It seemed like they were all in a nursing home. My parents live about 45 minutes east of here in Jersey Shore, Pennsylvania. They have 17 of the county's 22 cases from a Manor Care nursing home. And so it certainly is a problem. I worry about the reinstitution of travel. I think I read that Greyhound and Martz and a few others are going to start travel from Philadelphia and Pittsburgh back to New York City on in a week. And so I worry about that because that is a variable. The more variables you have, the more you have to worry about. I worry that a vaccine is not going to come as soon as we would. So let me rephrase that. A vaccine will not come as soon as we would like. I'm worried that it won't come in what the expectations maybe have been put out to date. So I think if history and science tells you when a vaccine might be available, we have that. I worry that we're gonna have COVID in pretty good presence, and we enter flu season. So do we make a campaign effort to try to increase our vaccination as much as we can for flu in the hopes that it helps with another public health event while we're having COVID? And so there's many things I think to worry about. I think the focus should be on saying what we know, acknowledging what we don't know, promoting the facts, meeting people where they're at. So we've got to talk to people on their level. And so we've got to talk to healthcare workers in a way that they understand. And so we got to give them the straight answer on many things. We've got to talk to the lay public very differently. And so if it were me, I'm concerned about opening up America again, a little too soon. I'm worried about a resurgence. I worry about the information a lot of times people compare this to seasonal flu. I just don't know why we even started that. That was a public health mistake in the very beginning to even compare this to seasonal flu. And so I think and then to the point, jails, prisons, meatpacking plants, nursing homes, and the notion that, hey, college students are of an age group that has been minimally impacted. They're in the 92% recovery. The only challenge with that is when you get back on campus, I don't think the average age of the professor is between 19 and 23. And so we need to look at things as a whole of community and not just the subpopulation. So the talking points for universities and colleges sounds really strong. Young, healthy, vibrant, will recover. Younger generation tends to be more compliant with vaccines, or whatever your argument is. And then my answer is, but if you take Penn State as a small town, my argument would be the average age probably skews significantly higher when you include faculty, staff, support staff, visitors, and then let's not forget spectators to events.
So we were talking a little bit about how potentially how to get it. With all of the that we've seen for flu vaccine, what do you think the public reception is going to be for a COVID vaccine, which is brand new disease we're still learning a lot about? They're going to accept the vaccine?
Yeah, so it's a great question. You know, I'm not sure. We're in uncharted territory, so some would argue that we probably should just assume that the same level of the population that gets the flu vaccine would likely get a COVID vaccine. We may find that to be very different. We may find that if COVID negatively impacted a community that was less likely to get a vaccine, then they might be more inclined to get the COVID vaccine. And so I don't know that to be the case, Jen, but it's possible. It also, I think some things are going to be based upon availability and marketing. And so some of it is going to be how widely available is the vaccine? Is it rolled out like we do with the Pneumovax or with shingles, where it's rolled out for individuals over a certain age? Is it rolled out for individuals that are a vulnerable population that have comorbidities? I'm not sure. Certainly, to develop the level of herd immunity others that we want, we wouldn't just target one community. But I'm just saying, if we have limited resources, I'm not sure what the sort of marketing and campaign and rollout plan would be for a new novel corona vaccine. But I think your question is a good one, which is what's the likely public perception and willingness to get the vaccine? And maybe you're right. Maybe as a good starting point, we should assume that, and I don't even know the numbers off the top of my head, but maybe we should assume that it'll be the same as on an average year for influenza vaccine. Not sure.
Thanks. So I know it's do you think an antiviral for treatment will be approved before a vaccine will be available?
Well, we already have an antiviral approved. Right now it's under an EUA, but it's certainly approved. I have to admit, I haven't had much time for scientific journal review this week. I think last week where I read, if I recall correctly, the study that came out that had the FDA issuing the EUA, I believe there was statistical significance for decreasing the amount of days needed to be hospitalized or in care, but it wasn't significantly significant for the decrease in the mortality rate. I believe, and if they've updated it, I have to admit I haven't looked at anything since Saturday, but we do have an antiviral that's under an EUA. If the question is broader, we're going to have an antiviral that is available without an EUA. I would say it probably is going to depend on what the results of these few studies that are currently ongoing reveal. But it certainly look promising. I would imagine that if the researchers, what they believe is going to be their final outcome and their published results are what they believe it's going to be, we'll probably have it available without an EUA. And then it just becomes a supply and demand issue, right?
So I know we're running a little bit long, but I do want to ask you one more question. One of the things that I did not mention in your bio was that Dr. Wolfe is a professor at the School of International Affairs here at Penn State, and also spent time as the associate director at the Center for Security Research and Education. So you're familiar with Penn State, with our students, and based on that experience and what you're doing on the outside, do you have any advice for people that are coming out of Penn State and looking to get into the public health preparedness field or the Homeland Security field, or anything that you wish you had known starting in your career path?
Yeah, so interesting question. So I would say, certainly, Jen, my answer is going to be a little biased, minus my 1 year here at Penn State working for Admiral Howe. I mean, I've been in the federal government my entire career, right? So I graduated in '93, went to the government in '93. And so, I've spent the better part of the last 27 years in government. And I'm biased to tell people that I find there's hardly a better place to work in my mind for the diversity of a career. So I think if individuals have a specific area they want to focus on in public health, so if it's the more traditional public health, then you're likely going to want to be, you're likely going to want to be, at a state or local public health department or a large healthcare institution. But I think, if you're not sure and you want the diversity, the government's a great way to go. I know it's hard to get in, but for students, try to do an internship, whether it's paid or unpaid. I tell people a great way to get around if you can't do an internship is try to work on a project for someone. I probably know 20 or 30 senior folks across government that if I said, hey, there's a student that wants to either work on a 10-page paper. Today, we don't even really want the papers anymore. We'd like to just have a project like what I just mentioned to you, someone giving you a tool that you can use. Those are great things, and you produce those for people. You never know whether that leads to an opportunity where they work. A lot of people who work in government have a spouse or a husband, wife, daughter, son who work in private sector that they can make a connection. So I think one, it's what part of public health preparedness, that's a pretty broad term, do you want to do? Do you want to be a frontline sort of first responder, first receiver? Do you want to do traditional public health? Do you want to do project management? If you want to do anything, I've had the same employer, for 27 years, but it feels like I've had a different employer every 3 years because I do something new with the government, but it's all still related to the public health preparedness field. I say lastly, if you really are Navajo Nation, and it's a mission near and dear to my heart. But I think if it's one of the areas where public health and public health preparedness is needed, and I don't think a lot of times those institutions and those of us on the East Coast, because we don't have many Native tribes and Native recognized tribes on the East Coast, we forget that we've got a large swath of the country that is, a Native tribal land, and we have a large healthcare system, and they certainly need a lot of public health practitioners, and they need a lot of folks who deal with public health preparedness, without a doubt.
So we often do have students that are looking for independent studies and different ideas for their capstone project. So if you've got ideas like those cards that you were talking about, please feel free to stay in touch. And if there's a way that our students can help out on projects like that, I'm sure that they would love the opportunity.
Yeah, and I think, the Penn Stater magazine reached out to me. I think, I'm going to try when this calms down, but we've got a lot of people, from Penn State that are in this, what I call the public health preparedness field. So the director of CISA at DHS, he's a Penn State grad, actually from the Homeland Security program, Brian Harrell.
Yep, he spoke to our students a few months ago.
Good, yeah, Brian's a great guy, and he owns the critical sectors, and healthcare is one of those. Dr. Birx is clearly going to have a lot of information to share with folks when her time on the task force is done. And so I certainly think keeping that avenue open between all of you and us, and I'm happy to try to play the conduit. It may be hard to get everybody together at once, but we could probably do a virtual, email or organization where if people had ideas, we certainly could do that. Josh Dozier, who's one of the senior executive folks at FEMA for the response, I know he's going to be leaving soon. He's another Penn State grad. So I think there's a lot of ways that maybe one of the things you could try to do is maybe just get an email distro of 10, 15, 20, 25 senior people in government who are Penn State affiliated or Penn State alum, and that might be a good group of people to be able to ping to see if they have ideas, and then they could just randomly submit them to somebody. So it's just an idea.
That's a great idea. I know that you're very, very, very busy right now, but when you get some more free time, if we could talk about this a little bit more and do that, that would be great.
Yeah, sure. I don't know where you're at when you're at work, but I'm moving over to St. E's, so I might see you or others in the Coast Guard more when we get to St. E's.
Oh, that's where. Well, when this is all over, that's where I am.
Well, we're moving to LL8, so that's where I will be.
Oh, we are on the 3rd floor.
Okay, so at least I'll be in the same building.
Very nice to know. Do you know when you're heading over?
Yeah, not till next year.
Okay.
Yeah. So.
Good luck parking.
I know, right?
That was one thing that they did not take really into account when they decided to put everybody at St. E. So it's been interesting.
Yeah.
So I know it's 9:19, but any last questions before we go? It doesn't look like it, but we did have Jeff say that this has been a fantastic webinar, and it has. This has been a lot of great information. So I really appreciate you taking your time, especially
Sure.
knowing the long days that you've been working right now.
I told him I was unavailable tonight, so when I'm done with you guys, I get a break. So this worked out for me as well too.
Nice. Well, thank you so much. And everybody who's on the line, I'm going to, I will post the link to this so you'll be able to review it.